Hello, and welcome to everyone. Thank you for joining us this evening for this webinar on research into severe neuromuscular conditions in children. We're really looking forward to a great discussion about congenital muscular dystrophies, congenital myopathies, Duchenne muscular dystrophy, inherited neuropathies, limb-girdle muscular dystrophy, and spinal atrophy. I'm Dr. Kate Adcock. I'm the Director of Research and Innovation at Muscular Dystrophy UK, which is a UK charity for individuals and families living with muscle wasting conditions. I want to just say a big thank you for the excellent questions you've already sent in. And if you want to ask a question during the event, please use the Q&A box or the chat box in the functionality of this meeting. It's the little speech bubble at the bottom right of your screen, and we'll do our best to answer it. To change how the speakers appear to you during the session, click on the three buttons at the bottom of the screen, which is next to the red telephone icon, and change the layout and select either the sidebar or the spotlight setting as you wish for the call. Unfortunately, we won't be able to answer any questions about individual cases. If you have any particular concerns about your particular case, please do talk to a healthcare professional. Tonight's been recorded and you'll be sent a copy of the recording in the next few days. And this event is being organised by the National Institute for Health and Care Research, or slightly more easily, NIHR. The NIHR is a government-funded body that can fund research in the NHS, and it funds research into public health and social care. And if you're interested in learning more about research, if you want to search for studies that you can take part in, or even sign up to be contacted about studies that interest you, then please visit the Be Part of Research website. Just search for Be Part of Research in your favorite search engine, but I think it's also being put into the chat for people to click on the links there. Remember, you can take part in many studies even if you don't have a health condition yourself. I'm going to be putting your questions this evening to Dr. Sithara Ramdas and Professor Laurent Servais, both of whom are from Oxford. And Sithara, perhaps I could look to you first to introduce yourself.
Thanks, Kate, and thank you everyone for joining us this evening. So my name is Sithara Ramdas. I'm a paediatric neurologist, and I have an interest in muscle disorders, and I lead the muscle service for children here in Oxford.
Thank you very much. And Laurent?
Hello, everybody. My name is Laurent Servais. I'm Professor of Pediatric Neuromuscular Disease at the University of Oxford. I'm very happy because I work with Dr. Sithara Ramdas. I also work a little bit in Belgium, where I'm born and bred. So if you have any question, feel free to ask. Sithara will be very happy to answer. If you have some softball, you can address them to me.
Fantastic. Well, thank you both very much. And let's kick off with the questions. And actually, the first one we're going to start with a few people have asked this already online. And with respect to clinical trials and perhaps even NHS approvals, where are we with gene therapies for severe neuromuscular diseases in children? Maybe Laurent, I can look to you first of all.
So we have a gene therapy product that is approved and that is reimbursed in spinal muscular atrophy. This therapy has been approved after a long clinical development in which there were several studies, including what we call a pivotal study, which is a study during which we assess the efficacy of the drug. If we want to go to the next kid on the block, it's Duchenne, and there is a lot of buzz because one gene therapy has just been approved in the US for the 4 to 5 years old, so a very narrow age group. To be approved in the US or in Europe or in the UK is slightly different because you can get accelerated approval in the US on the basis of what we call a biomarker. So you don't need to demonstrate a clinical efficacy. If you have a surrogate biomarker, so a biomarker that is reasonably correlated with the action of the drug, it's okay to have an accelerated approval in the US. In Europe or in the UK, it's not okay, it's not enough. So for this very specific product, there is a phase 3 trial that is ongoing, which is a pivotal study in which we have to formally demonstrate the efficacy of the drug. And the same applies for another gene therapy product, actually for in Duchenne also, and a third one is in phase 1. So the short answer is things are moving, but even if it's gene therapy, even if it's very severe condition, sometimes we still have to reach the benchmark and to demonstrate the proper efficacy of these drugs.
Thank you. And so by efficacy, you mean that it's safe and that it makes a change and an improvement or stabilization for people living with the particular condition?
Well, safety is of course a very important point. And safety needs, of course, to be balanced with the severity of the condition. If you have a condition that can kill the patient in a couple of weeks, you will probably be more, ready to accept side effects, right? That if it's a very chronic condition, but indeed with efficacy in the UK and in Europe, we talk about clinical efficacy. So it needs to translate into something that you can measure in the patients in terms of motor performance, in terms of stabilization of the disease. It cannot just be something you measure in the blood, something you see on the MRI. It cannot be a biomarker. It has to be a clinical feature.
Thank you. That was going to be my next question, actually. What did you mean by biomarker? So these are things that you can measure in the body, as you say, something that you find in the blood or in an MRI or in the urine or another sample that you could take from people.
Exactly.
Okay, thank you. I was going to also ask you about where things were internationally, but you've mentioned about the European and the US situation and how they're different from perhaps in the UK, which is really great. So thank you very much for that. You mentioned actually about Duchenne muscular dystrophy. So I wonder whether we could maybe just touch on that for a moment and just sort of, we've had a question from our audience to ask about why is Duchenne muscular dystrophy more common in boys than girls. So perhaps before we start on why it's more common in boys than girls, perhaps you could just give a little bit of information about what is Duchenne muscular dystrophy. And Sithara, maybe I could look to you first.
Yeah, absolutely. Thinking about Duchenne, so I'll just divide into starting sort of because this is about muscular dystrophy. So muscular dystrophy in simple terms means you get muscle breakdown as part of the condition. And the commonest muscular dystrophy that we see in childhood is Duchenne muscular dystrophy. Okay? And it's named after Duchenne, who described this condition, 200 years ago. So what happens in Duchenne is you have a particular genetic defect due to which the boys don't produce a particular protein called dystrophin. And dystrophin is a shock absorbing protein in our muscles. So all of us, when we are walking or running, our muscles are stabilized by the shock absorber. And if you don't have dystrophin, you get muscle breakdown, which then over time causes a loss of muscle and progressive weakness in the boys. So that is what happens in Duchenne. And why does it occur in boys? Is because the genetic defect in Duchenne is in a chromosome called X chromosome. So for those of you, if you remember biology back from school days, so we all have, we get 23 pairs of chromosomes, okay? And we have, if you're a girl, you have 2 copies of X, and if you're a boy, you've got 1 copy of X and 1 copy of Y. So in Duchenne, the gene defect is on your X chromosome. So as a boy, if you have only 1 X chromosome and that has the defective gene, you can't compensate for that because your Y chromosome doesn't have that gene and you have Duchenne. Whereas if you are a girl, you have another X chromosome which can compensate because you've got normal protein can be produced. The caveat there is there are a small proportion of girls who can also have what we not describe as typical Duchenne, but what we call manifesting carriers. So they can have some muscle weakness, but not as severe as the boys, because it depends on which X chromosome is active in a girl. So a small proportion can have Duchenne, but it's mainly in boys because boys only have 1 X chromosome.
Thank you very much. That's a brilliant explanation. So thank you. That's hopefully that's helped people understand more about why it's in boys and not more than girls. So moving on from Duchenne, we'll come back to some questions about Duchenne in a little while, but we've had another question about a condition called myopathy. So we'll come back to what myopathy is in a second, but the question is about how optimistic are you that ASO technology, and ASO means antisense oligonucleotide, another thing I think we might need to touch on as to what that means. So how optimistic are you that ASO technology, even developed as a next generation compound, can work as a therapeutic approach for myotubular myopathy and centronuclear myopathy? So there's a lot to unpack there. Maybe Laurent, I could look to you first of all to just talk us a little bit through what are myopathies and what's the difference perhaps between myopathy and muscular dystrophy.
Well, yeah, the difference between dystrophy and myopathy, sometimes we use the two terms one for the other, but this is not correct actually. So a dystrophy is a process in which the muscle is destroyed and regenerates, and destroyed, regenerates. So it's a cycle that unfortunately ends up into more destruction than regeneration, and which is a wasting process of the muscles, right? Myopathy is a structural condition of the muscle, so normally with no destruction. So the muscle is structurally abnormal, and it can be because there is an accumulation of something. It can be because the nucleus is not at the right place in the muscle. There are several causes, and then we enter into the brave world of congenital myopathy, which is a large group of disease that is characterized when you take a piece of muscle by a structural abnormality of the muscle fiber without this cycle of destruction regeneration. And the clinical manifestations can be very broad. It can start at birth or even before birth, and infants can be in respiratory distress at birth and severe hypotonia. And it can even start in adulthood, right? So they are what we call the phenotypic spectrum. So the type of clinical manifestation is very, very broad. And one of this myopathy is what we call the X-linked myotubular myopathy, so another disease for Dr. Ramdas, was related to the X chromosome, like Duchenne. So same explanation. So it affects boys, and the most common form is extremely severe. These boys at birth are very floppy. They are in respiratory distress. They cannot swallow, and interestingly, they cannot even move the eyes, which is a quite appealing clinical symptoms. And the story is that there are several approaches to treat this myopathy, and recently there was a gene therapy trial using a capsid of a virus in which we placed the gene, and this was incredibly effective. So if we could infuse these patients with this gene therapy product, many of them started having a fantastic improvement, being able to sit, being able to walk, and could even be weaned off ventilator. In 23 patients, unfortunately, 4 patients died out of the 23. So this was a terrible ethical challenge, as you might imagine. On one side, you have something that works incredibly well, but with the cost of a high mortality related directly to gene therapy. The trial is on hold, but what we've learned at the bare minimum is that if you are able to re-express myotubular in the muscle fibers of these boys, you have a possibility of improvement which is absolutely dramatic. And as you might imagine, even if this product cannot go on the market because of the toxicity, the potential toxicity, it opens the way to other approaches, because we know that as long as we are able to restore myotubular into the muscle cells, we can potentially dramatically improve these patients. Problem is that myotubular, X-linked myotubular myopathy is a little bit more complex than we initially thought, and there is also some subclinical liver involvement. So in any approach, we will be potentially limited by liver toxicity. The good news is most of oligoantisense nucleotides have very few liver toxicity. It's more renal toxicity. So again, to make a very long answer short, I think that we still have several options open for this specific myopathy, given the dramatic efficacy that was shown during the gene therapy trial.
Fantastic. And the thing of ASO technology, so the antisense oligonucleotide, that's different from a gene therapy?
Definitely. Gene therapy is the capsid of a virus from which we have removed the DNA of the virus. So it's just, you know, the
like a ball.
In which we place a promoter in the gene, right? And we infuse very high dose of that, and we have the right for one shot, because after that there is a immune reaction against this virus that we infuse at such a high dose, and you cannot infuse anymore. Oligoantisense nucleotide is a completely different approach, in which we will inject something that looks like RNA, because you probably know that DNA, which is our genetic code, is translated into RNA and then into a protein, right? And at the RNA level, there are several post-transcription mechanisms. An oligoantisense nucleotide is something that looks like RNA, but it's not RNA. It's much more robust, right? So it's not destroyed by RNA, so you can infuse it or you can inject it intrathecally, and it can go in front of the RNA, of the natural RNA, and interact with the splicing process, with this post-transcriptional process, and it can be incredibly efficient. And we have an example. We have several examples of oligoantisense nucleotide that have been approved and that are available in the UK. The best known example in the neuromuscular field is definitely nusinersen, a drug that is used in spinal muscular atrophy, which was the first drug available for spinal muscular atrophy. So yes, it's two different mechanisms with two different burdens and two different potential toxicity, because it's important to understand that when we speak about clinical trials, about new drugs, this is fantastic, and we think about efficacy. We need also to keep in mind this comes with a potential risk and with potential toxicity.
Fantastic, thank you. And Sithara, I'm going to look to you for a second, because Laurent used a few technical terms there, and I wonder whether you could help us out with one or two of them. So he mentioned about renal toxicity. So can you just mention what that might mean?
So toxicity in simple terms is side effects. So when we have, any medication, unfortunately comes with side effects, and it's always benefit versus risk. So when we mean renal toxicity, means it's affecting the kidneys. And that can present in different ways. So as part of clinical trials, as you know, for those who have participated, there's quite rigorous monitoring of bloods, urine. So we check to make sure the kidneys are not leaking too much. So kidneys are really important because they're sort of filtering of your body to make sure they keep all the good proteins, but all the toxins from your body is normally leaked out in the urine. So if you have a drug that is causing problem to the kidney, then that can affect how your normal body will manage normal proteins and these things. That's why that's a very important organ to monitor for. The other is liver. Liver also is sort of a filtering organ in our body. So we always monitor to see if the liver enzymes can be an indicator of the liver saying, I don't feel well. So that's something that's quite closely monitored. And the other, particularly neuromuscular disorders like Duchenne, we always look at the heart, because we know the heart can be affected in muscular dystrophies, but some of the drugs that we give, particularly in gene therapy, we have seen affecting the heart particularly. So as part of clinical trials, and that's what's the difference between clinical trials and when a drug comes into what we call clinical practice. In a trial, there are very rigorous sort of protocols to follow, rigorous testings on specific days, specific times. And that's where the commitment for the trial comes for a child and a family, because we have to follow that protocol to make sure the drug is not just about benefit, but it is safe. And by the time it comes to clinical practice, we have all that information from several trials where lots of patients have had it to know, okay, how regularly do we need to monitor a child or a patient's, blood count or kidney, this thing, or liver. And that's where, all that information comes from, and what side effects we would counsel patients and families about.
Brilliant. Thank you very much. That's really helpful. I'm going to move on to another condition or group of conditions now. Somebody has asked whether there are any research developments in limb girdle 1B and that might benefit their child, and how will this affect children in the future? I think perhaps again, if we can rewind a little to first of all think about, and again, Sithara, maybe you can answer this. What is or what are limb girdle muscular dystrophies?
Okay, absolutely. So again, remember I first talked about the muscular dystrophy, and Laurent also mentioned, muscular dystrophy, you get progressive muscle breakdown, regeneration, but over time, muscle wasting. And limb girdle muscular dystrophies are another group of muscular dystrophies, different from Duchenne, because they affect various different proteins. So there's about 26 different types now. And the name limb girdle comes from the pattern of weakness that we see in these patients. So they have particularly weakness in the limb girdle, which is around the shoulders and around the hips, at least initially, and then that might progress over time. And there are, like I said, different types. So some of them can run in families, what we call autosomal dominant, or some are what we call recessive, and the recessives tend to be common. So the particular type that's mentioned, 1B, is what we call autosomal dominant by a very particular gene called laminase C mutation. And this muscular dystrophy not only just affects the muscles of the arms and legs, but also is one of the muscular dystrophies where heart can be quite affected early on and requires quite rigorous heart monitoring and things. So what treatment options are there? So I think as a group, limb girdle muscular dystrophy is another group of muscular dystrophy where there has been quite a lot of at least lots of preclinical work, and now certainly in the, not in 1B, but in the other types, several gene therapies in the pipeline, both in clinical trials and preclinical trials. I'm not aware specifically for 1B if there's an option, but Laurent might know more. But what I would say is generally what we know the proteins that are affected in these type of muscular dystrophies, and there are strategies being developed to address these protein defects, either through gene therapy for the genetic defect or through ASO, this thing technology in general. So we will have more trials coming in limb girdle muscular dystrophies as well in the coming future.
Okay, Laurent, putting you on the spot, are you aware of any trials for 1B, limb girdle 1B?
So look, when Sithara doesn't know, she asks me, and when I don't know, I ask clinicaltrial.gov. Just for the sake of the joke, but not only, there is no doctor who is aware of all clinical trials in the world. This is just impossible, right? And when it comes to limb girdle muscular dystrophy that Sithara describes, there are today more than 30, 40 different limb girdle muscular dystrophy. So I'm not speaking about all possible congenital myopathy, congenital myasthenia. So there are so many diseases that nobody is aware of all clinical trials. So if you want to know, there are several websites, and one of them is clinicaltrial.gov, which is the one I use, but I have no shares, so feel free to use another one.
It's also be part of research, which will have links to UK trials.
Exactly. Be aware that whatever is the site that you look at, they are very serious trial that is conducted by very serious investigators, and they are trials that are dangerous and that are conducted by people who do not follow the rules. And unfortunately, the fact to be registered on clinicaltrial.gov or any website does not mean that they are serious. There is some type of filters, but it's not controlled completely. So when you see, if you want to look for a very specific condition and you find a trial, go one step further before contacting straight the investigators. Then you can discuss with your doctor, who maybe doesn't know about this trial, but at least is able to check the curriculum of the principal investigator or the company to see if it's serious or not. So again, to make a long story short, it's possible to check online if there are clinical trials, and it's possible also to try to figure out if it's serious or not. And there are some trials that are not safe.
Great. Well, this leads us nicely on to the next question, which is about whether there'll be a time when clinical trials are less centralized and devolved to local hospitals so they can be maybe more accessible to all patients. We're sometimes trial sites certainly in the UK may only be in 1 or 2 centres. So do we think that that might be easier? This particular family had to travel 10 hours in a round trip for a clinical trial last year, which was actually far more exhausting and challenging than being part of the actual trial itself. And Sithara, you're nodding, so I'm going to go to you first.
Yep, no problem. Absolutely. And I think, that's something, you've raised a very valid point, and that's something that as a neuromuscular community that we are looking to address in the UK. So what I would say is we need to think about clinical trials, again, as you've participated in trial, how do we do that? It's not possible for every district general hospital to run a clinical trial in children in neuromuscular disorders because it's a rare condition. So when you have rare disorders, the expertise will be, unfortunately, in the UK in children's hospitals, and there are only 14 neuromuscular centers. So there will be geographically, there will be some travel involved. Yes, currently, if you think 5 years ago, we had only 3 or 4 neuromuscular centers doing clinical trials. The number is 3 or 4 times now. So, most neuromuscular centers are now actively participating in clinical trial. So in answer to that question, yes, we are improving the access to clinical trials as researchers across the UK and clinicians to make sure we can try and treat patients as closer to home as possible. But it will still be children's hospital because you have to have the infrastructure, the clinical expertise, the research infrastructure, and simple things like access to a pediatric intensive care or respiratory doctors, things which will not be available in district general. But as most patients do travel for their neuromuscular appointments to children's hospital, they will be hopefully in time able to access clinical trials there. Also important to remember, not every center can do every trial because trials are in rare disorders. So there will always be, centers. Some trials will be in a few centers, but what will be is hopefully as a condition. So for example, if we take Duchenne, there will be access to at least 1 or 2 trials in the center that you're linked to that might be suitable for your child. But if it's a very rare condition like, congenital myasthenia, it's unlikely every center will have that. So that variation will be there depending on how common the neuromuscular disorder is in a rare group of disorders. But along with the NIHR, like DMD Hub and clinicians, we are trying to improve trial capacity in all children's hospitals.
Fantastic. And I suppose sometimes it depends on what the actual drug or gene therapy is as well, because of the complexities around that. I mean, Laurent just mentioned about the gene therapy where there are potentially liver complications and what have you. So you need to have the whole of the infrastructure around you to be able to manage those trials.
Yep, absolutely. And safety and having that expertise is really crucial because the last thing, like Laurent said, you don't want people who can't follow the rigors of clinical trial or have the expertise to just do clinical trials like that. It has to be delivered safely by a team who can pick up things and monitor things and have the expertise. And that takes time to build up and teams to build up. But it's a work in progress. And I think we are improving and will continue to improve in the UK.
That's fantastic. Brilliant. So we've got another question now. This is related to Duchenne muscular dystrophy, and how close is the world to being able to stop the progression of Duchenne muscular dystrophy? Laurent, any ideas?
I'm maybe going to be a little bit pessimistic, but we're not even close, to be honest. We still have a lot of work, and this is hard to say, but this is just the reality. We will be able to stop Duchenne muscular dystrophy, the day we are able to bring full dystrophin on a regular basis. Today, the best we can do is to bring a truncated version of the dystrophin one shot, or to bring a very reduced amount of truncated dystrophin through oligoantisense nucleotide. We will be out of the wood the day we will be able to bring the full protein on a regular basis. The good news, if I might say, is that there are some works in progress at the very early preclinical level. It's promising, but we need to understand that between the number of drugs that start clinical development and the number of drugs that finally gets approved and reimbursed, the attrition rate is 24. It means that you need 24 drugs that enter the pipeline of clinical development to get a single one that is approved and that is used in clinic. So again, we need to manage expectation and to be clear on the fact that even if we have promising approach that will potentially come in clinical trials in the coming years or so, it's not the reason why we should say today, well, don't worry, in 5 or 10 years it's done. This is exactly what we were saying when I was a baby myologist 15 or 20 years ago. And at that time, it was the first phase 3 trials in Duchenne, and everybody was so excited, and we are expressing dystrophin. At the end of the day, we're not much more advanced today. I think that today, the future of Duchenne muscular dystrophy is certainly to try to combine these different approaches that work a little bit and to use them the most intelligent way, which is probably as early as possible for many of them.
Mm-hmm.
Not all of them, because gene therapy is a one-shot, so it depends on the weight of the patient, so maybe it's better to wait. But it's very likely that there are many approaches that we could actually start before the age of 2 years. And there is a kind of artificial limit, which is 2 years, because we're not able really to capture efficacy before the age of 2 years. But it's very likely that for such a chronic condition, to act much earlier on would be much more efficient.
Mm-hmm.
So, again, short answer, we're not even close to cure Duchenne, but we are progressing on a step-by-step approach, and we will still need years and years and years of clinical trials before we are actually able to stop Duchenne and then to cure Duchenne.
I think that's a sobering reminder that clinical trials are still research programs. They're not a treatment. This is what people are doing amazing things by being participants in clinical trials to help doctors like you understand what works, what doesn't work. And obviously it's very heartbreaking sometimes when a trial doesn't come to fruition because something hasn't worked, but we learn so much from that process. So yeah, I think that's important to remember. I'm going to move us on to another question now. So it's a question about myotubular myopathy again. So remember, this is one of the conditions again that is more affecting boys. So is there any research happening around strengthening the bone density in boys with myotubular myopathy, and what could be the reason for low bone density in this condition, and what are the implications? And Sithara, again, you're nodding vigorously, so I'm going to go to you.
So I think in simple terms, low bone density is very common in neuromuscular disorders, as general as a rule. So and myotubular myopathy is one of the most severe congenital myopathies. So we tend to see low bone density in them. So this is for several reasons. So one of the important aspects of bone density is how our muscles move. So when we move, when we walk, when we move our muscles, the muscles build up, the bones build up. So that's how they happen. So if you have a severe muscle condition like myotubular myopathy or SMA, you're not moving your muscles as normal, you've got weakness, that affects bone density. Second, vitamin D exposure is very important. We live in a country where we have 5 days of sunshine, so all of us are low in vitamin D. But if you have a neuromuscular condition, you're in a wheelchair, again, that might limit your access to how much you're outside, playground things, so your vitamin D levels can be low. So that can again affect bone density. And then, So I think what we say is, I'm not aware in myotubular myopathy specifically if the myotubular affects the bone, this thing, but generally in all severe neuromuscular disorders, we do see low bone density, and we proactively monitor patients for that, monitor their vitamin D levels, do a specific scan called the DEXA scan, which is like an X-ray to see how the bones are, and if they develop fractures or the DEXA is getting worse, then we ask the endocrine doctors to see them, because there are bone strengthening medications that can be given. Yeah. Are you aware of any specific research, Laurent, for specific bone density? So I think it's just generic part of myopathies, not just myotubular. Yeah.
Fantastic, thank you very much. And there's a question here about sort of related in some respects, I suppose, that the best dietary advice for those with limb girdle muscular dystrophy. So, but I suppose again, is there dietary advice in particular for any of the conditions that we're talking about this evening? And the particular questioner is asking about limb girdle, is asking whether leucine supplements can be beneficial, and I suppose it might be worth touching on what's leucine. I don't know who wants to pick that one up, Laurent.
Yeah, I mean, those who came to my clinic knows that I've got a motto for nutrition. I used to say our neuromuscular patients should eat what we should all eat if we were not crazy, right? Which means healthy diet with vegetable and fruits, drinking water rather than soda. If we want a juice, to take a fruit, to squeeze it and to get a fresh juice rather than to buy juice that are full of sugars. So that's actually a healthy diet that I would advise to anyone, not only my neuromuscular patients, not only my patients on steroids, but to everyone. And of course, life without Belgian fries is not life. We all know that. But you're not supposed to eat Belgian fries every day, right? Otherwise, it's not party anymore. You can eat it, I don't know, once per month, and it's enough. So I think it's important to keep in mind that to eat is a pleasure, but that it is a pleasure if such pleasure like Belgian fries is an exception, not the rule, right? And so I think it's important to stick with this opinion that we all need a healthy food, our neuromuscular patients also. It's important that our patients have no rapid fluctuation of the weight, because we all know that to have a neuromuscular condition, if all of a sudden you take 5 kilos, it's not muscle. Most of the time it's fat, right? And if you start losing a lot of weight very quickly, most of the time you don't lose fat, you lose muscle. For a healthy person, it's not so much a problem. For a person with a neuromuscular condition, if this person loses 5 kilos and then take 5 kilos, it's not like ASO. It's not like if nothing has happened. Most of the time, muscle has been destroyed during the weight loss, and fat has been taken during the weight gain. So we need to try to get a weight which is constant. Of course, in children, it needs to increase, right? But with no rapid fluctuation up or down. If the patient wants to lose weight, it needs to be properly scheduled with an acceptable number of kilos per year, and it needs to be done also with exercise, because otherwise it's mostly muscle that will disappear. And then comes the question of supplementary supplement. In general, except in very rare exception, there are very few strong studies that are really that really demonstrates the interest of any diet supplement. But let's imagine it doesn't cost so much and the patient wants to try. It's always possible to say, well, I would like to try something. It doesn't hurt. Maybe it can help. And to make a good measure, a good evaluation of the patients, and then to try to see 6 months down the line if it has helped or not. And most of the time, it has not really helped, and it's fine. At least we've tried. But I don't try to discourage my patients to try over-the-counter approach, but I try to discourage to do it like, okay, let's try a little bit of this, let's try a little bit of that, let's make a kind of cocktail, and a little bit of creatine, a little bit of coenzyme Q, a little bit of tyrosine or whatsoever, and then supplement, and then multivitamins, and at the end of the day, you swallow many things that have actually no real nutritional value. So I'm perfectly fine if my patients wants to try something because they've heard it on Facebook, if it's safe, right? But then let's do it by properly measuring the patient's performance, having an objective, and being able 6 months or 1 year down the line to accept to face the truth. Does it work or not? And if it works, so far so good. I'm not trying to convince my patient it doesn't work if my patient feel it does, right? But at least to try to be honest, and if it doesn't work, that's fine. I mean, probably in 2 years down the line we'll have another idea.
Oh, fantastic. And there's a sort of related to that, there was a question in the chat that came in this evening about the supplementation of boys with Duchenne with creatine, for example, and what age can this be given from?
I mean, there is nothing that shows any, that even suggests any significant effect. So I don't prescribe it, to be honest. I don't see so much the rationale, also, to be honest. Let's imagine that I meet in the consultation a mom who is strongly convinced and she really wants to try. And I would propose to make, according to the age of the patients, to choose 1 or 2 scales or 1 or 2 tests that we do properly before trying, and then we can see 1 or 2 years later if it has helped or not. And we need to be humble as doctors. You know, sometimes things cannot work at the population level, and sometimes on one single individual it can help. So it's okay to try if it's safe, and if you do it in agreement with your doctor and you properly measure and you have a realistic objective with whatever you try.
Fantastic, thank you. This is a really interesting question that's coming from the chat. Is there any research being done into the more effective management of some of the common symptoms of these conditions? For example, secretion management. Medicine seems so few and limited in their efficiency and daily life managing that this is just so difficult. So I guess maybe Sithara, you can touch on that.
Yeah, no, I think that's a really good point, because it's day to day, which is really important for our patients and families. And yes, we're looking for that, you know, the treatments of the cure or this thing, but how do we manage the symptoms now? So in answer to your question, is there management specifically neuromuscular disorders for secretion management? No, there isn't any specific research for that, but what we do have strategies of managing secretions in neuromuscular disorders, which might be slightly different in managing secretions than a child who's got another type of neurological disorder. And that's where I think the expertise of a team with neuromuscular expertise, a respiratory physiotherapist, a respiratory physician, and neurologist is really important, because it might be, you know, so lots of our children have very ineffective cough because of your muscle weakness. So part of the secretion management would be devices like LVR bag or cough assist. So it'll be those strategies. Managing secretions is always challenging, because the secretions can't be too thick, because then that's very difficult for our children to cough out, and, you know, because they've got weakness. Equally, if they're too thin, they're drooling, and, you know, that's having an impact on day to day. And it really is a bit of a trial and error with the medications that we have, that you have to find the right balance for each child at the right level. And what I would say is it really is team working together with the neuromuscular expertise and the patient and the family and the community therapists together to find the right balance for each child. And there isn't one thing will fix it all strategy. It will be very different for each child, you know, depending on what respiratory status they have. So if a child has got a tracheostomy, ventilation, and IV, the strategies, you know, would be slightly different compared to a child who doesn't have respiratory support. But there are medications, there needs to be optimal physiotherapy input, and there needs to be medical input coming together. But there's no specific management specific for neuromuscular disorders for secretions.
Thank you. Thank you. Maybe that's something to for the future. Yeah. So here's a question that's probably again going to be a game of two halves, because there's a question here about from the chat this evening concerning the second generation of exon skipping. Is there any hope that it will produce sufficient amount of dystrophin to support all necessary functions, or is it too early to say? So I suppose this is talking about restoring the dystrophin for boys with Duchenne muscular dystrophy. And if you could just maybe, Laurent, explain what exon skipping means as well for for people?
Okay. So you probably know that our genetic codes is done with 4 different base, what we call ACTG, right? Adenosine, cytosine, thymidine, guanine. And with these 4 letters, ACTG, we make words of 3 letters, like ACT, TGG, CTG, GCC, and so far and so on, right? So it means that in a big gene like dystrophin, if you miss, a part, but you keep the same reading frame. So, for instance, if you remove just AAC, well, it's not good, but at least you still have quite a long gene that you can read, right? But if you remove AAC and then the G just after, you can actually get all the everything which is downstream, the mutations, completely impossible to read, right? If you want a very famous example, it's like if you have a sentence with words of 3 letters, like the big fat dog saw the red cat. The big fat dog saw the red cat. If you just miss big, B-I-G, you have the fat dog. So, well, you don't know it is big, but that's fine. You understand what happens, right? But if you miss just the B, you have the X, and it's just impossible to read, right? The principle of the exon skipping is to remove the part that is flanking this type of deletion, this type of hole, to make the hole a little bit larger, a little bit bigger, but to keep it in frame, right? So if, for instance, you miss the B, to remove the I and the G, and you have the fat dog, so the red cat, right? So that's the principle. So this works only for structure protein. Like if you have a big dystrophin, you remove a small part, it's still okay. If you have an enzyme like myotubular, which has a very, very strict function, and it needs to have the exact good shape, it doesn't work, right? You need to have something that is a structured protein. So dystrophin is typically the type of dystrophin protein for which it could work. The problem is that with the 3rd generation of exon skippers of PMO, we could restore 1% of dystrophin. 1% is not enough. I mean, it is very, very few, and we even not sure that it can really translate into a clinical benefit. But the main issue being the amount of drug, of antisense that you can bring into the cell. And with this new generation of oligoantisense that are conjugated to a protein, to a peptide that allows a better penetration into the cell, it seems that we can express much more dystrophin. And there are several trials that are ongoing in the UK to skip exon 51, exon 53, soon exon 45 with this type of new generation. What can we expect? Well, it seems that it's reasonable to expect re-expression of 6 to 10%, which is not that bad. And then the problem is not so much how much you express, but also when you express. Because as you might imagine, if you re-express at a moment where there is no muscle anymore, it will not work as well. So probably that's going to be, I think, quite a major advance in Duchenne, when we have exon skippers that work, being able to deliver in a very young baby, when the muscles are still in a good conditions, in order to preserve the muscle cells. So it's not so much a question of how much are we able to restore. It is also a question of when are we going to deliver these drugs, and are we able to deliver it in the newborns?
Fantastic, thank you. And very briefly, because I'm conscious of time, we've only got a few minutes left, and there's a great question just coming up about exercise, but I want to just touch on something about that you were mentioning about where in your sentence, going back to your big fat cat, dog, I can't even remember what it was.
So the red cat.
If you lose something at the beginning of the sentence, obviously the whole of that sentence then becomes jumbled. If you were to lose sort of something at the end, is that likely to have sort of less effect, if you like, on the gene, or does it again depend on whether it's structural or whether it's an enzyme or something? It's sort of gene dependent.
Exactly, and on top of that, within the gene, you have neopromoter. In the middle of the gene after exon 5, we know that there is a neopromoter. So things are always a little bit more complicated than stories of big dogs and red cats, as you might imagine. But yes, short answer, things is a little bit more complicated. I agree.
Fantastic. So going back to the question here, which was about exercise, which is a great one, it came in the chat this evening. So thinking about exercise, can people with neuromuscular, how do people with neuromuscular conditions approach this? And is there any research around that? There seems to be very limited number of studies and resulting guidance, and the guidance may not always be appropriate for different conditions. So Sithara, maybe you can touch on that.
Absolutely. So I think the simple answer, we start with the exercise is important for everyone, including patients with neuromuscular disorder. But the exercise need to be, adapted to a child's or a patient's abilities with the neuromuscular disorders. So there's not what we call randomized big clinical control trials, but there is research about ongoing benefit of exercise with small trials in different neuromuscular disorders, particularly like myasthenia and SMA as well. So what I would say is it's important that exercise is part of a child's or a patient's routine, and it can be adapted to their abilities. So the resources to access is a neuromuscular physiotherapist who can liaise quite closely with their community physiotherapists, access, what opportunities are available in school. Like, for example, if you're doing PE, the child might join for stretching part of the PE or the initial 10 minutes and then do something else different. Our patients who are using wheelchairs, there is programs like wheelchair basketball, wheelchair football. So there's different sports that they can access. So all of this, I think, is something that we talk a lot in our clinics about exercise, and particularly for children, I think it's really important that they're part of the peer group, the playground, PE, which is really important on day-to-day life to participate, be part of that. And that's where these activities come. And then the additional benefit on their neuromuscular disorders. So yes, we really encourage our patients, and we try and find the strategies to help adapt things for them to make sure, they're able to be part of a day-to-day life. But I think adults with neuromuscular disorder also exercise is really important because, yes, it's not about trying to run a marathon or a 10K. It's trying to be active, whether that's just going for a walk for half an hour every day, going up and down the stairs, things like that, to keep your muscles active is important.
Fantastic. Thank you. And going back to the question before, actually, a little bit, I think about the where the mutation in a gene has occurred. For gene, does it matter where the mutation on a gene has occurred for gene therapy, and would it be effective if the patient and would the patient be a candidate for treatment? So I suppose, Laurent, that's one for you, if you can briefly touch on that.
So short answer is yes. Well, for Duchenne at least, there are mutations for which the risk of an adverse reaction is much, much higher. So it's not so much for a matter of efficacy, it's much more for a matter of safety. So in SMA, it's easy because all patients have the same mutations. In X-linked myotubular myopathy, it was absolutely not related to the issues, was not related to the mutation. So short answer is yes for Duchenne, but mostly for safety reasons, not so much for efficacy.
That's interesting. Thank you. So there's a question here about for many children with Duchenne muscular dystrophy, the only available drug is corticosteroids. And actually, I know for a number of other neuromuscular conditions, children do have steroid treatment or some particular conditions. Are there any drugs being trialed that help reduce or balance out the side effects of corticosteroids? Because obviously being on corticosteroids for a long time, you mentioned about side effects earlier on, Sithara. Is there anything out there?
Yep, absolutely. So yes, there is a particular drug called vamorolone, which has completed a phase 2 and a phase 3 study. So thinking about how do corticosteroids work in Duchenne? So we know part of what happens in Duchenne is when you get muscle breakdown, and then when the muscle regenerates, you get inflammation, and the steroids dampen the inflammation, but come with a whole host of side effects. So vamorolone is, in medical terms, is what we call a steroid analog. So, works similar to steroids, but the side effect profile has been noted to be slightly different, in particular from the clinical trials, which we know the data so far is the weight gain seems to be lesser. The boys, particularly Duchenne boys, tend to be quite shorter, so the height doesn't seem to be as affected in the boys on vamorolone, but it does still have the other steroid side effects in that, particularly affecting puberty and the adrenal suppression. And what we can see from the trial, sort of mainly for a Duchenne population, is that the effect of steroid and vamorolone, when they were compared, particularly daily steroid and vamorolone at a high dose, was similar. So it seems to have the similar benefit on maintaining the muscle strength. But the data we have is only for a few years. We don't have long-term data like we have for Duchenne, which is 10, 15 years. So the short answer is yes, there is a particular compound that has been developed and has completed a clinical trial. It's awaiting EMA and MHRA approval, which is the first step for any drug to be available in the UK. And after that, they will be nice. We'll look into that to see whether that would be approved. And if it does work in the similar ways, the strategies that we use for steroids in other muscular dystrophy is the similar mechanism. So we use it for some of our limb girdle muscular dystrophy to reduce the muscle inflammation. So hopefully if it works in Duchenne and it's helpful and this thing, that might be a strategy that might come for the other limb girdle and other muscular dystrophies in the future.
Fantastic, thank you. There's a great question here which sort of speaks to something you touched on before, Laurent, about are there many trials out there for children with Duchenne muscular dystrophy? And I suppose that speaks, are there many trials out there now for other conditions as well? So I guess, Laurent, if you can just quickly answer that, I'm mindful of time.
Yeah, so there are trials in many conditions, not only Duchenne muscular dystrophy. Of course, as these conditions are less common, the number of sites are also smaller. So the best example being nowadays limb girdle muscular dystrophy type 2I, for which now we have clinical trials ongoing. And there's been also several gene therapy trials in other limb girdle muscular dystrophy. There is no nowadays a drug that is testing Becker muscular dystrophy. So short answer is yes. Obviously, Duchenne remains a flagship of clinical trial. We need to keep in mind that in spinal muscular atrophy, we still have quite a number of trials in using, for instance, anti-myostatin. So short answer is yes, and this is going probably to continue, which underlines the need to have the proper information for the patients.
Mm-hmm. And if people are interested in getting involved in clinical trials, of course, they can be part of research and speak to their doctors as well to find out about trials. I am very mindful of the fact, actually, I've just looked at the time. By my clock, it says it's 1 minute to 8 o'clock, and we're due to finish at 8 o'clock. So I think, I'm very sorry we couldn't answer every single question today. It's been a fantastic evening, and thank you for everyone who's joined the call to be involved in asking questions and sending questions in advance. I'd just like to thank you both, Sithara and Laurent, and thank everyone for providing questions. I hope everyone has found it an insightful and informative session. I, as ever, have always learned something from speaking to the both of you, so thank you very much. Also, thank you to our hosts, the National Institute for Health and Care Research. And for those people who are watching online, if you want to learn more about research and how you can take part in studies, even if you don't have a diagnosed condition, if you're a child or an adult, do search for the Be Part of Research website. There's an awful lot of information on there, and it's growing all the time. You'll be sent a recording of tonight's event as well as an evaluation form, so please do take a moment to complete it. We want to run more of these kinds of events, so we want to know what we're getting right and what we could do better. So finally, it just remains me to thank you all again. Thank you for your participation. Thank you to Sithara and to Laurent, and I hope you have a really wonderful evening. And bang on the nose of 8 o'clock, I'm going to say goodbye. So thank you, everyone, and goodbye. Good evening.
And thank you, Kate, for excellent chairing.
Yeah. Thank you, Kate. Thank you so much. Bye-bye.